The following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by independent educational grants from AstraZeneca and Johnson & Johnson.
Hello, and welcome to another episode of AUA University Podcast. I'm your host, Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today, we are diving into a topic that's become increasingly relevant in day-to-day urologic practice: the evolving treatment landscape for low-grade, intermediate-risk, non-muscle invasive bladder cancer. This is a topic that every urologist, academic or community-based, manages, but one that continues to evolve in a surprising and meaningful way. The low-grade, intermediate-risk, non-muscle invasive bladder cancer group is an area where the definitions keep shifting, the evidence base is expanding, and we suddenly have new tools like chemoablation, new delivery systems, and increasingly nuanced guidelines. These innovations in urology are reshaping how we care for patients and how we think about bladder preservation and quality of life. I'm thrilled to be joined by a familiar voice in this space, Dr. Chad Ritch, Professor of Urology at the Desai Sethi Urology Institute here at the University of Miami. Dr. Ritch is an accomplished clinical researcher in bladder cancer and someone who has published extensively on practical treatment and surveillance paradigms that we use today. Chad, welcome, and thank you for joining us.
Thank you, Dr. Gonzalgo. It's been a pleasure joining you here, and really honored to be here and discuss this important topic with you. As you mentioned, it's a rapidly evolving landscape, and whatever I can do to share my knowledge and to educate folks on this topic, it is truly my pleasure. Thank you for having me.
It's wonderful to be with you here today. Chad, let's get started. I want to start with definitions because intermediate risk non-muscle invasive bladder cancer can be a surprisingly broad bucket. And depending on who you ask, low-grade intermediate risk and small high-grade intermediate risk tumors are often lumped together, even though biologically they may behave differently. So can you walk us and the audience through how the AUA SUO currently defines the intermediate risk category?
Right. So, the intermediate risk category, it can at first seem a little bit confusing. It's sort of a catch-all of, a hodgepodge of low grade, and as you mentioned, a very specific high grade type of tumor. But first, if you look at it from the, what it's not, so an intermediate risk tumor is not solitary, small, low grade tumor, first time diagnosis. That would be low risk. So, that's just one thing to clear up. Although a low risk tumor is a low grade tumor, if it's a new diagnosis, small, solitary tumor, that doesn't fall into the intermediate risk category. Similarly, large, multifocal, high grade tumors that have been treated with BCG, variant histology, the worst of the worst, obviously not in the intermediate risk category. So everything else falls into this intermediate risk bucket. So basically, you start with low grade, and if it's recurrent or multifocal, then that's intermediate risk. If it's a large low grade tumor, that's intermediate risk. There is this sort of odd entity, if you will, low-grade T1 tumors that would also fall into intermediate risk. I rarely ever see that, few people do in practice, but for purposes of the guidelines, that's where it would fall as an intermediate risk. And then, of course, you mentioned this high-grade solitary, small, less than 3 centimeter tumor that would actually fall in the AUA SUO criteria for intermediate risk. But some people would debate that because it's high grade, they wouldn't want to put it in that bucket. And we've studied it in our cohort at University of Miami, and we've shown that, it actually doesn't behave dissimilar to some of the big multifocal low-grade tumors in terms of risk of recurrence and progression. But, it is high grade, so people argue the biology is different. But for the purposes of kind of where a lot of the field is headed and, where these newer drugs that you had mentioned, chemoablation and so on, are focused, mostly it's recurrent low-grade, large low-grade tumors that encompass the bulk of these intermediate risk AUA SUO groups.
Got it. You mentioned something, and maybe you might want to expand on it, because clinically, these types of tumors don't always act the same. And in practice, I think many of us still view low-grade and high-grade intermediate risk patients through very different lenses. Excuse me. Particularly when discussing recurrence risk, progression risk, and choice of intravesical therapy.
Yeah. Yeah, no, definitely. I mean, I think a lot of us still kind of lean towards when we see a high grade tumor, even if it is an intermediate risk, possibly using something like BCG. Whereas for like a low grade tumor, that's intermediate risk, we probably would lean towards chemotherapy. In the guidelines, it doesn't explicitly state that that's what you have to do for high grade intermediate risk, but at the end of the day, I think the same, high grade gets BCG, low grade gets chemo kind of thought process is where most of us still, focus.
Right. So, this is a perfect setup for our next section, how we treat these patients based on what we know now. All right. So let's talk management, and we'll talk a little bit more about the intervesical chemo versus BCG, et cetera. But the TURBT, we all realize, is a starting point, right? But what comes next depends heavily on some other factors, including age, comorbidities, quality of life. Look, even travel distance for patients and financial toxicity is relevant. So when you're talking to your patients after you've done that TRBT, can you just walk us through your approach for initial management and treatment of these patients? Again, keeping in mind that they've been diagnosed into that low-grade intermediate risk category.
Yeah. So the first thing I try to do when I explain, like, especially the low grade intermediate risk group to patients and kind of what that means as a big picture, I always use this analogy, and many people also use this of sort of like plucking weeds in the grass. They pop up from time to time. We have to get rid of them. Sometimes you can just keep plucking them, but it gets really tedious, and you may have to use, pesticide or something to help you, become more efficacious in your weed plucking, if you will. So, I use that analogy to explain to the patients that these things will come back often. They may not be life threatening, they may not be dangerous. And that's why you're in this quote unquote intermediate risk bucket. So once I've framed that to them and sort of allayed their fears that, hey, I'm not going to lose my bladder, I don't need major surgery, I'm not going to die from this necessarily, but I may be dealing with a lot of cystoscopies and TURBTs. So I set that up so that they have some perspective on what the next 3 to 5 years might look like. Then I explain to them, look, you have options of, we can just watch you, and if we see another one, we'll do the same thing over, we'll resect. I always do counsel them on single installation perioperative chemotherapy, so they know to expect that on the day of resection. And then follow up as far as, do you get chemo, do you watch? That's where all the things you alluded to, age, their travel distance, financial toxicity. So if I have a 75-year-old patient who's in a home that her daughter has to take work off to get her from the home to bring her there just to get 6 weekly installations of gemcitabine, I may say to them, look, she's not going to necessarily die from this. Yes, it may help to reduce the number of TURBTs, but at the same time, if you guys are experiencing a lot of financial distress, it's hard on her physically to get from the home, then I may say, let's take our chances and monitor you. So that's where, that question comes into play. And then if I've had a patient who, let's say, is a very high risk when it comes to anesthesia, cognitive decline, you don't want to have to put them under, I may say, look, even though you have to travel here and get installations of chemotherapy, maybe it's worth it to avoid you having to have more anesthesia and avoid doing a TURBT. So anything we can do to prevent a recurrence, even if it's modestly efficacious, we'll try it. So that's how I kind of tailor things to different patient scenarios.
Great. I think that's one key take home, and just highlighting that single installation of chemotherapy immediately following the TURBT, we know can reduce recurrences up to about maybe even 35 to 40%. It's such a simple intervention, and it still amazes me how often it's underutilized. My next question really relates to the historical approaches that we've used for intravesical therapy. So BCG and gemcitabine. We'll talk about some of the newer agents, which really is, I think, one of the most exciting things in not only bladder cancer, but our field. But can you just comment on the use of either BCG or gemcitabine or medomycin, basically the intravesical chemotherapeutics, in the context of the AUA guidelines?
Yeah. So, specifically in the intermediate risk group, The guidelines kind of ushers people towards using more chemotherapy than BCG, and that's one sort of take home here, especially in the era of BCG shortage, right? Yes, you can use it in a low-grade patient, and I myself, as I'm sure you have, had certain patients who've had so many recurrence. Now, this is before the time of some of these newer drugs we'll get into, where you sort of run out of options and you want to give them something else. So you try BCG, even if it's a low-grade patient, and this is their fourth, fifth recurrence of a multifocal tumor. But I think sort of in the sequencing of things, most people would start off with intravesical chemotherapy. Here in the US is gemcitabine or mitomycin. I think mitomycin, in the aqueous form still sort of is less widely utilized because of concerns about dysuria and, cystitis and that sort of stuff. So gemcitabine, mitomycin, and then from there, you can evolve depending on the patient scenario to using something like BCG.
Great. So this is the part of the episode I think that many listeners will be most interested in. Okay, the novel chemoablation treatments that have been introduced, and perhaps other new approaches. For example, we now have our first FDA-approved chemoablative agent that's available for patients. Can you comment on these?
Yeah, like you and many others, I'm excited about this space because, it does get frustrating as a surgeon to spend all this time resecting, and a few months later you see tumors that are there and you're like, oh, I got to go resect all these tumors again. And even with the advent of blue light and things that help you to become better resectionists, even if you want to talk about, homeonucleation and how effective that could be in this space. But one of the things that you think about is how can I potentially avoid having to do, especially an extensive TURBT in somebody who's had a recurrence for the, second, third time. And that's where chemoablation really looks appealing. So say you have a patient, and we'll talk about the inclusion criteria in the trials, but, just real world scenario, you have a patient comes in, this is their third recurrence, you're the third urologist they've seen. They have multiple 2-3 centimeter tumors, low grade appearing, always have been low grade. Studies, and even before the trials that we'll discuss with reverse thermal mitomycin gel, studies have used aqueous mitomycin, aqueous gemcitabine, even BCG to sort of ablate these tumors. And the concept is, you see the sort of target lesions there. Yes, you should biopsy it beforehand, but let's say you biopsy one, you confirm it's low grade, then you instill the drug for weekly for like 6 weeks. You can actually have a CR, meaning those tumors will disappear at your first 3 months cystoscopy. And this is without a TURBT. In other words, you didn't resect these tumors. You just basically instilled the drug and ablated them. And again, this has been done with aqueous chemotherapy before, the newer drugs, the mitomycin gel, and so on. In terms of efficacy, though, just the aqueous solution, it's okay. Most of the studies like 30 to 40% CR. So, the concept of having a drug, the same drug, which is efficacious, but with a longer dwell time that can stay in the bladder, it makes sense. Now you're talking about something that could potentially move that CR needle up to, a higher number that us as urologists would get behind. So yeah, so the idea of chemoablation is very appealing. It's something that has been done before. And if happy to talk about what's out there and the drugs that are available for this.
Yeah, I think that that's very interesting and exciting at the same time, because the idea of chemoablation is appealing to patients because that may mean no TRBT, right? Less morbidity, and in essence, an office-based treatment. I also think that this, might have the ability to offer this to older or maybe comorbid patients who might not tolerate repeated resection. So that could be a game changer as well, not to mention reducing anesthesia exposure. Wanted to ask and to focus a little bit. Again, you mentioned obviously this intravesical mitomycin. Well, I'll use it. It's Susaduri. Again, the first FDA-approved chemoablation therapy for patients in this group. Can you comment a little bit about what was shown in data to provide benefit for patients?
Yeah, so exactly. So this, mitomycin reverse thermal gel, Zosduri, which is first FDA-approved drug in this space for recurrent low-grade intermediate risk bladder cancer, used for chemoablation. So, the sort of landmark trial where there were two sort of trials that led to the approval, but the main one was the Envision trial, right? So single arm, phase 3 trial looking at the Zasturi, or UGN-102 was the drug, where basically they instilled it in patients, 6 weekly doses. Patients had a target lesion, which they biopsied, confirmed it was low grade. The other lesions remained, and then they instilled in the patients, again, 6 weekly installations, similar to what we would do currently. And then they looked at the CR rates. So, sort of the first thing that jumped out at you was the 3-month CR, which was pretty high. It was about 80%. So if you remember when I was talking about aqueous solutions of gemcitabine, mitomycin, it was like 30-40%, and those were all retrospective series. Now we have a trial which showed that. And then, from there, the next thing you want to know is, okay, well, it's great that 80% had a CR, but what was the durability of that, at 1 year? Now the study still lacks long-term follow-up, but if you look at about 12 months and then out to 15, to 18 months, it's still up there at about 80% of those patients that remain free of disease. So disease-free survival is the endpoint, around 80%, after about a year. And that's pretty good. I think the biggest caveat, which we all would, agree on, is when you have these single arm trials, you don't have a comparator, right? So it's great if you have this drug, you showed a great CR, but, you're not comparing it to anything. So the CR doesn't necessarily mean that it's all because of drug. It's not a randomized control trial comparing it to, say, aqueous mitomycin or something else. Before this trial, they had, as you know, the Atlas trial, which is where they also looked at the same drug compared to, another arm of TURBT. And although they did show similar CR rates at 3 months, the disease-free survival, longer term follow-up favored the UGN-102 arm when you used it in conjunction with TURBT. So that also, kind of supports the drug, saying, hey, this may work, in the long term.
Yeah, no, again, I think the bottom line is an exciting new treatment that's available for patients in this particular risk group for bladder cancer. And I think everyone's appreciative of that. So, let's pivot now to surveillance, okay? Because low-grade intermediate risk disease, the burden of cystoscopies can be enormous over a patient's lifetime. So, Chad, can you talk to the audience for this podcast a little bit about how you approach tailoring your follow-up strategy for these patients?
Yeah, and again, I try to stick to the guidelines in terms of for an intermediate risk patient, I would say at a minimum every 6 months, but the guidelines will tell you at 3 to 6 months for the first 2 years, and 6 to 12 months for the next 2 years, and then annually thereafter. The other thing that I think is a good take home from this podcast, and I always tell like my residents and fellows, when you see patients who have low grade tumors that are recurring very often, don't forget about the upper tracts, because it's this sort of seeding phenomenon that you'll occasionally see where somebody has a small upper tract tumor and you've been resecting and resecting, and then it just looks like a bomb went off in their bladder 3 months later with like multiple tumors scattered everywhere. And then you're like, man, this is, either I'm doing a really bad job at resecting, or this, intravesical therapy is useless. But sometimes there's these upper tract tumors. So I would say at a minimum, every 1 to 2 years, you should do upper tract contrast-based imaging. So that's another important part. One thing I think potentially we can do, and this is where, as you alluded to earlier on, tailoring it to the patient, financial toxicity, age, and so on, is we looked at our own cohort at the University of Miami, and we said, for these sort of intermediate risk patients, what if we kind of modeled out a less intense surveillance strategy? So we had one that was 3 months, one that was 6 months, one that was 12 months, cystos. And, essentially what we found, which as you'd expect, yes, you may miss a few tumors with the 6 months and 12-month surveillance strategy, but the sort of oncologic risk, like you're not risking grade progression, you're not risking, stage progression. You may just sort of delay the diagnosis. So kind of what I've tailored things to is I always tell patients, look, we can cysto you every 3 months, but if we do it at every 6 months and it's easier for you and less stressful, that's perfectly fine. We're not running a major oncologic risk there.
Yeah, I think, you point out, and we recognize this for those patients who we treat who have bladder cancer, that financial toxicity is a real issue. And, look, the cost of repeated cystoscopies can add up, not just financially, but also in terms of time, travel, and anxiety for our patients. So I'm glad the guidelines now kind of officially support a tailored approach for patient management. So let's focus now on the last portion of our talk about the future. Can you comment what's on the horizons, and future innovations in this space?
Yeah, it's like a lot of things in non-muscle invasive bladder cancer that the space is heating up. There is a need again because patients want treatments that help them to avoid having surgery. Also avoid the anxiety of knowing that tumors have returned. And I think that this space is uh, somewhere where we can really make an impact on patients' quality of life, not just the oncologic efficacy, but if we can avoid cystoscopies and TURBTs, this space is somewhere where there is a need. And so for that reason, I think a number of companies, so CG Oncology is looking at cretostimogene, which you're probably familiar with in the high-grade BCG unresponsive space from the Bond trials. So the Pivot 006 trial, which recently accrued as an intermediate risk, non-muscle invasive bladder cancer, recurrent intermediate risk, and hopefully we'll see a signal there. It's a little bit different. It's not chemoablation. It's adjuvant therapy, similar to what we would give as gemcitabine or mitomycin used after a TRBT. Just for the audience, as a quick recap, cretostimogene is basically an oncolytic, replicating oncolytic virus, which goes into cells that are deficient in retinoblastoma pathways, and essentially it lyses the cells and creates this tumor immune response that helps to prevent recurrences. So Pivot 006, that's one trial, so we'll look out for that. The other drug, which is pretty interesting, and it was kind of studied in one of the trials, is erdafitinib, so for FGFR alterations. So the Thor-2 study was basically a trial looking at erdafitinib, or the oral drug, which is for tumors with FGFR alterations, in a combination of high-grade, high-risk patients, but they had a small cohort of intermediate-risk patients in the Thor-2 trial. It's like 18 patients. And interestingly, they used it as a chemoablation drug, and they found it was 89% of patients had a CR at 3 months. So there's a signal there. The only thing with erdafitinib, and this is sort of like, going back to the days of when Keytruda or Pembro was introduced for high risk BCG unresponsive bladder cancer. Erdafitinib is an oral drug, has a whole new host of side effects that we as urologists aren't that familiar with. Like one of the things in the trials that was a little bit concerning was a number of the patients had a small percentage had this thing called central serous retinopathy, which is basically an issue with visual acuity that can happen when you take the drug. Now, if you're a urologist and you have a patient with like visual problems afterwards, it's kind of like, whoa, I don't know how to deal with this. But, it's something that if that drug comes into this space, we may need to become familiar with. But again, erdafitinib is something to look out for, as an oral agent. And just, kind of in the same vein, that drug, because it's again pretty novel, is actually being used in a novel drug delivery system. So we're all familiar with TAR-200, which is a new drug being used in the BCG unresponsive space. But you can put any sort of therapeutic on the delivery system. So TAR-210 is where they use erdafitinib on the drug delivery system, and that's being explored in intermediate risk non-muscle invasive as well. So that would be something interesting to look out for.
Great. Again, a lot of exciting developments in this area, and I want to end on kind of just your thoughts and comments on risk stratification of patients. These are in the guidelines, so we recognize it as an important starting point, and even along the continuum of treatment. What are your thoughts on kind of the molecular tests or distinctions within non-muscle invasive bladder cancer, and perhaps some of the urinary biomarkers or other markers out there that may help better risk stratify patients?
Yeah, so I also think this is an exciting space. So, we're starting to see things like, AI-based histopathology that can sort of risk stratify patients. We're all familiar with, molecular profiling that we use in advanced bladder cancer, and it's making its way into the non-muscle invasive space as well. So as I mentioned earlier, there's a number of alterations in non-muscle invasive like FGFR3, Believe it or not, there's alterations in the HER2 pathway. There's the TERT promoter is another one. So there's a lot of unique signatures in non-muscle invasive. And similar to how, when it was explored, looking at molecular profiling and basal versus luminal and muscle invasive, people are looking at similar subtypes in non-muscle invasive bladder cancer. So there's a lot of work being done on molecular profiling to sort of substratify, if you have just a large low-grade tumor versus one that's been multiply recurrent, is that biologically different, and is there something we can target? The second thing that you had mentioned, which is urinary biomarkers, similarly, and as you know, we're looking at this as well with CX bladder is one, and Caris molecular profiling, but you can potentially avoid some of these cystoscopies if you have a good urinary biomarker that can tell you whether a patient is, NED or not. And, the intermediate risk space would be a good area, obviously high risk too, but if you could avoid some cystoscopies, you chemoablate a patient, you use a biomarker, and then, now you're talking about doing maybe one cystoscopy a year in those cases. So I think it's an exciting area that needs further exploration.
Yeah, no, and I think that's a great way to kind of wrap up this podcast in terms of the new agents that are available for treatment, and all of incorporating all of these factors, including, as you mentioned, chemoablation, can ultimately redefine the patient experience. It can affect and improve the burden of care and the economics of bladder cancer management. So with that, Dr. Ritch, I would like to thank you for an excellent discussion and for sharing such a balanced, evidence-informative perspective on this evolving area of bladder cancer. And to everyone listening, thank you for joining us on this episode. We hope this conversation enhances your understanding of low-grade, intermediate-risk, non-muscle invasive bladder cancer and helps you navigate treatment choices with confidence. For our listeners, if you'd like additional resources, guidelines, and CME materials, please visit auanet.org/university. I'm Dr. Mark Gonzalgo. Thanks for being with us, and we look forward to bringing you another episode soon.